two-part series. This is Impact of Injuries, Part 1. I'm Allie Knight, LPGA and PGA certified instructor, and I'm here with Dr. Mark, performance specialist. And today, the impact of injuries, it's something that all athletes and almost everyone goes through at some point in their life. You're going to be injured. I know for me, I've been fairly lucky to not have anything severe, but there was one time where I've hurt my neck really bad. I went to the chiropractor, or somebody that was gonna give me a massage, and got my neck cracked 3 times, and from there
Didn't turn out well.
it didn't turn out well.
Yeah.
I found myself not being able to move my head, and it was devastating.
While needing to play in a tournament, no
Yes,
less.
yes, at a golf tournament, and not knowing what to do if other than take a bunch of ibuprofen and hopefully when's it gonna kick in, because every time I'm swinging I'm in pain.
Yeah.
And at that point it's that decision of, do you play or should I not play? Am I gonna hurt myself more? Such a hard decision on that. And I think at that point I was like, well, if the ibuprofen kicks in, I'll be okay. But when you're crying in the bathroom trying to decide, there's a lot going on.
There's a whole lot going on.
Yep. If it's physical, emotional, fear, and what's the best way to go about that? Like, how do you know where's to draw the line?
Right. So common question. And my first response to that, which at the end of the day I will stick to very staunchly, will be that is always a decision best made with a medical professional. Even in that moment of I'm sitting here crying in the bathroom at this tournament, it's always best to either say, if I don't have access to a medical professional, then all bets are off until I can have that discussion with one. You're always better off, and your best decision is always, I will stop until I have that. Now, in your case, my daughter's case, some other people's cases, they will sometimes have that blessing and benefit. It's interesting for me, and it's a little personal side tangent, but people often forget psychiatrists are physicians, right? So we went through med school, and you don't go straight into psychiatry. I had to go through all the rotations, everything from a family physician to everything else, before I just said, no, I'm only working on the brain, and in my case, neurology as well. So we've seen the injuries, all that type of thing. So in those particular cases, again, for instance, my daughter, sometimes you can at least pick the phone up and, Dr. Mark, here's what's happening. What can I do? And that's not to say I'm an orthopedic. I'm not. They're going to know far more what to do, but I could at least tell you either look, I know this means a lot, but the odds are in your favor that you're not going to get hurt. You're okay. If you don't have that kind of an access, it's never a bad thing to say, this particular tournament or match or whatever it is not worth a potential lowering of my quality of life for the rest of my life. Because, in your particular case, you had, I think we ended up being very lucky that I think you went on to play, and it kind of worked itself out. It sounds like it was really kind of more soft tissue type of things. And so you were very lucky. But if that had been someone, for example, the cracking had impinged a nerve in their spine, they could have had one swing and been a paraplegic the rest of their life. So that's a risk that's, like, at least for me, I'm not willing to take. And I think if you talk to most people, whether it's before or after, they would tell you, yeah, that's a risk I'm probably not willing to take. But there's other things that's all very contextual. You know, we talked a bit about this off camera, a bit of love to create a checklist for people that says, okay, question one, am I having this? Yes or no? Yes, go to, no, go to, kind of like an algorithm.
Yeah.
You just go down your algorithm and you check it out. And then you make your decision, right? If only life was so easy. Unfortunately, it's only that easy for accountants, not for the rest of us. Because there are gray areas in life, whether we like them or acknowledge them or not, they're there.
Yeah.
And so the biggest thing is I instead tell people, instead of looking for a checklist, go back to your priorities. Right? So, for example, we should all have a priority to try to live our life as healthy and pain-free and as free as we possibly can. If there's a potential in any way for that to be taken away, the decision is no. Then I love the follow-up to that usually is, but how do I know that? How do I quantify that? You can't. You don't. Right? You have to take the best judgment you have with what you have. In your case, you know, I didn't chuckle at you, but I chuckled inside a little bit to say, if you're standing in the bathroom crying, that's probably an indication I'm done today. Right? That's not to say I don't understand that internal drive.
Yeah.
Of no, I got to push through this, right? And there are times when that is very valuable and a very good thing. That's a whole other episode in and of itself,
I
right?
think that's our whole culture. Let's push through it, and then you end up more hurt.
Bingo. And so here, that's kind of unfortunately what the actual statistics tell us are that more times than not, it's a negative outcome. But we're taught the opposite.
Right.
There's a great book, and I apologize for not remembering the author. I just remember the book because the book was very impacting. I even have given it to some patients throughout my career. It's called Quit. Right. And it's this, I'm trying to think, I believe it was a psychologist. And again, I apologize. And if the author is watching this, please reach out to me and give me the details. Knowing you personally will help me remember everything. But essentially it takes both a mathematical statistical look at when to quit. So that very question you have is, how do I make that decision? And it walks you through the logic and the actual statistics of not knowing when to quit. That most of us end up hurting ourselves by not quitting.
Yeah.
Right. And injury is no different from that. So whether it's well, do I take this job and leave this one, or do I this, or do I that, or do I this, or do I that? Same decision. On a base level, it's the same decision, right? It's a risk benefit calculation. And so the best way to make that decision is just that, which is why I say it's a little more subjective than just being able to give you an algorithm or a checklist, right? Is there's some subjective, personal, principle, priority things there that have to be taken in that I there's no way I could know and tell someone, here's how you decide that. There's also why back to my original statement and say that decision is best made with a medical professional, not because they're going to know that, but just the action of discussing it with that person. They're obviously going to know some things. Like we know the prevalences of certain injuries and the outcomes, right? So more so than anyone else, that's our job. Having that and being able to give you some data around that, but also just giving you very honest feedback of you're saying this, but then you also seem to feel this way, and those things are opposed. How do we reconcile that? You know, a family care physician, anyone can help you with that. Obviously, if it goes beyond a certain level, I'm going to recommend you go seek a mental health professional. Really dig through that. But, yeah, I do. I so wish I could give you.
Yeah.
I so wish I could give you just an easy answer. Here you go. Check, 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 check. I'm good. Check, 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 check. I'm not good. Fortunately, it's just not quite that straightforward. In your very same situation, there could have been someone with slightly different circumstances, both arising to it. And at those circumstances, I might have given a completely different advice to than, for example, I would have you. And we know the kind of the devastation of it. I mean, look at someone like Tiger Woods,
Right.
who unfortunately, in my opinion, I certainly don't speak for him. It's just in my opinion and observation, his career essentially is over because of very severe lower back pain. I weep for him because I know that pain. Two, even the ramifications outside of the physical for him. I understand that. Now, good news is he still stays very active in the golf world and does amazing things. So I think he's where he should be now. But I'm sure, I don't know, but I'm sure that if I had him sitting here talking, he probably would say, oh, no, I'd love to wave a wand, get this over with, and get back on the course. Always have to kind of take these type of things in consideration.
Yeah, and that's in all my TPI training and stuff.
Yeah.
The lower back, that's the number one
The
problem that happens to
34%
golfers.
of golfers.
Wow.
The top three is the lower back's 34%, the wrist, the wrist, because it goes back, wrist, shoulder. So 20% roughly, wrist injury. The next highest at around 17, somewhere between 15 and 17% would be shoulder.
Yeah.
So those are the obviously.
And that's with the TPI, the lower back. What we learned was a reverse spine angle was one of the biggest causes on that. And then I would say
when you just for my own clarification, when you say reverse spine angle, what does that mean?
So just when kind of taking that backswing, you're leaning or reverse
you're tilting.
Reverse C is another way people would say where you're tilting toward the target.
We learned kyphosis lordosis.
Okay.
But that has to do with the spinal from this, whether it's curved in or whether it's curved out.
Okay.
Right. Okay. And so I just want to make sure, like, I don't think that's the same thing. So thank you. Yeah. I appreciate it. But I could totally see that
because you're way, then you're going to have to go back that way to compensate. And
well, and there's we actually did some calculations and some studies, and the compression forces and the angular forces that occur during that. I will go over those actually in a minute for you, but they're a little mind-blowing, to be quite honest with you. Like, you have forces sometimes up to 8 times your own body weight.
Yeah, and I've heard that, like the golf swing is a whiplash.
Yeah, absolutely. Yeah. And I'll even kind of, for the physical part of it, episode 2 will go more into the psychology, the psychiatry, those type of things. But for the physical part of it, I'll even go over some of those kind of kinesthetics and body dynamics and some of the forces involved in that. I can even remember doing them, like, wow, I never would have thought that. Now I understand why 35% of people have lower back injuries.
Yeah.
It's
and I would say going to the wrist, I think I've had a lot of people come in, especially in the winter. We go on the mats.
Yes.
And they are pounding ball after ball on these mats, laying on cement. And they ask, oh, my wrist, my elbow.
I say elbow would be the other one, because I include the elbow in the wrist. Not totally, but I think wrist is 20%, elbows 15%, and then shoulders just slightly lower than that. But I would include. So the other one's going to be your either your lateral or your medial epicondylitis. It's going to be the other thing that happens. So I was just getting ready to say it. I bet they can play their elbow too.
Yeah. So they don't realize when you're hitting on the mat, it's just that there's no give on the
and
grass.
there's a friction surface there that it's stopping the club.
But I think the big thing on all these is once you have that first sign of something hurting, stop.
Yes.
And rest. And because what happens is we keep going and we keep doing it, and then that's when we get a real big problem, and that's when you get longer to recover.
You get in trouble. So there'll be. We'll get into it here a little bit later. There's things called microtraumas that occur with overuse predominantly, And I deal again more with kind of the professional, kind of elite level athletes. These happen in amateurs. They occur in both. They just occur with a little bit more prevalence in professionals, right? Why? They're playing significantly more than amateurs. That would make sense because you have something like, I believe the prevalence or you know, amount of injury you see in a professional kind of elite golfer ranges up there to almost 75%. So almost 75% of professional athletes have some form of a significant injury at some point in their career, right?
Wow.
As opposed to 55, 57% of amateurs.
Okay.
That's still a high percentage. Like you think over 50% of people playing golf have a lower back, or wrist, elbow, or shoulder injury at some point.
Wow.
And they do. So what you're saying and what that means is, to me, what you're saying makes it even more important to understand those physical injuries, right? So, for example, you understand how these injuries occur. I always start with the how and the why, and then we can move into the, so here's what we do, right?
Right.
And that's just kind of how I've been trained. It's been beat into me and how I think. But so, for example, in a golf swing specifically, you have the swing mechanics, right? So X factor. Your X factor is the angle between your hips and your shoulder turn. So in professional golfers, that can actually be up to almost a 57-degree angle, as opposed to an amateur, they're hovering at best somewhere around 45 to 50. Right? So that angle and that degree of turn is putting significant stress and strain. Final, bone column goes back to kind of what you were saying, where TPI is like, well, the lean, right? So oftentimes they'll calculate now, particularly for a professional, the X factor, right? And you're wanting to maximize that X factor. It generates more power, which also generates more force, which also generates higher probability of injury.
Yeah.
And so people can get a little bit myopic about it. And those are the individuals I always have a little bit more concern with. Of you're setting yourself up. You're going from a 75% chance to a 95% chance.
Right, like long drives.
Yeah, I don't go to Vegas on those odds because I'm coming home broke. It's that's one thing about the new way kind of teaching a little bit sometimes, just the golf swing itself, because the X factor is there whether it's taught or not, right? So that turn and that angle differential. The next one would be ground reaction forces, right? So and this is a pure physics problem. To be honest with you, it's when you shoot a projectile and it goes at X degree at X velocity, it's Newtonian physics, pure and simple. So most people don't think about it because we think the shoulders and the turns and all that kind of generating everything, but none of that occurs if the ground didn't push back. So if I was able to make you hover over water and try to do a golf swing, good luck. Right? You can't. If you try to do a golf swing in space, good luck. Right?
Yeah.
Why? Because we require that reaction force of the ground pushing back on us to actually generate acceleration and power. Right? So that ground force determines the acceleration of the club.
Right.
Now, what that also does, and you got to keep in mind, I'm isolating these things, but all of these things are happening and are part of a much longer and a variable in a much longer equation. So isolate them, but always keep in mind they're actually interacting with each other. So by generating that ground reaction force, you can have up to a double to 1.5 to 2 times the force compression of your own weight on your spine. So for example, if you weigh 100 pounds, you can have anywhere between 200 and 400 pounds of compression force slamming your spine together.
Mm-hmm.
Right?
Yeah.
When you look at it that way, you kind of think, I got to take up croquet. But again, when things are done right, training's right, you're loosening your muscles right, your body can take these type of forces. It's okay. It just makes you want to really pay attention to how you're preparing well. That you are preparing well. The last one is the kinematic sequencing,
Mm-hmm.
right? So, again, and this is almost Newtonian physics again.
Mm-hmm.
So the golf swing goes when you take those ground reaction forces, you combine it with that X factor, you have the force goes from proximal in us to distal outside of us
Right.
or away from
Yeah.
us,
Hips.
right? Right. So
Torso.
it goes
Arms.
from here out, and particularly in a golf swing out to the end of the club.
Mm-hmm.
Well, remember the concept of leverage or a lever?
Mm-hmm.
So if I want to move a large object, I simply get a longer lever, and it magnifies the force by quite a bit of factor. And so I can now move a boulder 8, 10, 12 times my own weight.
Mm-hmm.
That same thing is happening as that force is being projected out into the proximal of that club.
Right.
The amount of force that proximal force on your spine, on your tissue, on everything, it's being multiplied with each inch, centimeter, whatever your unit of measurement wants to be, of that force distribution. Mm-hmm. So you start with a relatively smaller force and you end with a very large force, which also means to some extent the backswing in terms of injuries, or not the backswing, but the follow through in terms of injury can actually begin to play an impact. How are you softening that force? Because when you try to abruptly stop it, all you're doing is transferring every single grain of energy of that force into your own body and muscle. So I love to see people swing and bounce the club off their back, where the club literally hits their back and bounces off. I love to see that. Why? Because it's allowing your own back and the solidity of your back to lessen that force impact on the actual spine and muscles. And it's something I'll often tell instructors of, teach your students from as early as you can to bounce the club off their back.
Well, and I think some of this too, that's why it's important to, if you have that professional nearby that has a force and pressure plate system or K-vest,
Yes.
where you can see that sequencing of your swing and your
Yes.
ground forces. Because if you're using those things incorrectly, coming down with the club first,
Yep.
you're gonna hurt
Yeah.
yourself. And it
Exactly.
should
Yeah.
be
Or
hips, torsos, arms,
exactly.
then the club is
Yeah.
the sequence.
Or at the
and then
very
arms.
least, you're placing yourself in a much higher probability of injury. Granted, young people are a bit like flubber; they bounce back from anything. But particularly as even as you get into the college age and beyond, that starts to decline. And so I would agree with you. I love working with people when they have those types of things around that we can utilize, because you're right. We now can quantify some of this and actually then begin to look at, here's the specific area where this is going out of balance or whack, and let's concentrate there, as opposed to that. That also goes back, and this again could be its own episode at some point, but I am a vehement, staunch adversary of the one swing mechanic fits all. That doesn't even make scientific sense. I'm sorry. That doesn't even make common sense. You're telling me we have literally an almost infinite number of body types in the world, and only one type of swing fits everybody? What are you? That's kindergarten thinking. No. That's unfortunately far more prominent than I would like for it to be. That everybody's swing is the same. No, it is not, ever.
Correct.
Using things like that help us individualize those swings for people. Now that doesn't mean there aren't ranges of mechanics that everyone should be in, right? I'll use, for example, the X factor. This is a great one. I think you and I had this conversation one time because I myself have had multiple, spinal surgeries, and so I simply don't have mobility that I had back in my youth when I could compete in golf.
Yeah.
So we were talking at one point about you noticed like my hip turn just was not quite there. I had this discussion of, well, I would love for it to be there, but I quite literally have a spine that won't allow it anymore, and so it's locked, and so okay, now I need to individualize my swing.
Yeah, exactly.
Right, and so that was exactly what we started doing, and I can swing without pain. I can play rounds. I can do things. Will I ever play in the senior PGA? No, but I pretty much had no chance of doing that to begin with.
Right.
So okay, I can go play around. I can even shoot better scores just by paying attention to that.
And that's why it's so important.
Agreed.
When someone's walking in to get a lesson, one of the first things you should ask,
Evaluate.
do you have any injuries? Because
Correct.
that could be
Or
why they're not
and I would say just
in their swing.
add on that limitations.
Right.
What about someone with scoliosis?
Exactly. Exactly.
You try to fix their swing based on an X factor. They're going to the hospital, and we're going to be lucky if they're not paralyzed. Their spine naturally curves to the side.
Yep. Yep.
That's a problem, right? But as opposed to let's look at this, work with what you have.
Exactly.
And so that individualization is, I think, very key. We're developing technology now that I'm getting a little baffled at what's the reason we don't utilize this technology that we have at our fingers, whether it's AI or things like simulators that give you swing data like that. There's all this data available that can individuate a swing and make it so much better. And my favorite is, and I've come across a couple of them where there's these staunch traditionalists, and the golf swing, there's only one way to have a correct swing. And I say, really? Who's won more FedEx Cups than anyone? Jim Furyk. How technically sound is that man's swing?
Yeah, I know.
Right? Most people will tell you it's not technically sound at all.
It's wild.
But you know what? Man can win because he's swinging his golf swing. And for me, that's the trump card, so to speak, is he learned to swing his golf swing. Therefore, he tore it up. Hall of Famer, most likely. That I think there's more to that in our world than at least I myself would like to see. But I could also be on the other end of that spectrum for all I know at this point. But and I also think, in addition to the topic here, individuating would significantly reduce chance of injury. That's where that kind of blends into this topic. It's not quite as tangential as it might initially appear. Because the other part of that, and this is related to the individuate the golf swing, is the number one reason for injury. So we looked at what are the highest probability or the highest injuries, right? What's the number one cause of injury, right? The number one cause of injury is overuse.
Yeah.
Particularly in elite and professional athletes, right? So I mean, we're talking 80% of injuries. So 80% of the injuries that occur actually can be traced back to overuse. There's research evidence out there. I'm really honestly not pulling numbers out of the top of my head. These are published, peer-reviewed, respected studies that look at this, right? So what kind of happens is when you have an overuse type of situation, because we talked a little bit about this off camera some, is for a professional, you can easily average around 2,000 swings a week between practice, play, and everything.
Yeah.
Right? That's a lot of swing. It's a lot of that. It's a lot of that momental force that we talked about, right?
Yeah.
What happens is you get to a certain point and your muscles, everything begin to get fatigued. It really kind of starts with the muscles there, right? But it starts with the muscles, but they start to get kind of fatigued unconsciously. You don't even realize this is happening. And for professionals like yourself, your automaticity of your swing is so well ingrained, and there's a whole other area of research on that that shows you literally, if I put you in an fMRI, a magnetic encephalography, right? So, which is a really fancy way of saying we look at the firing of the cells in your brain and they create a magnetic field, and we read that magnetic field, right? So, not an MRI shows you, because people are like, oh, an MRI. No, an MRI shows you structure, right? This shows you what's called an MET, right? MET shows you activity. Right. So if I were to do functional MRI or MET on you, and then and several other professionals, and then I did it on kind of an amateur population, and this was a study that was done, right? So again, not making this up. This is an actual study you can go find and read. It shows that for professionals, you quite literally have a rewiring in certain areas of your brain. There's certain areas of your brain dealing with your golf swings that have an entirely different activity and an entirely different wiring than, say, an amateur.
Yeah.
So we could get philosophical and be like, well, chicken or egg? What was it? Did you naturally have a better wiring, or did you acquire that wiring? My answer is going to be yes. At the end of the day, and I will let philosophers figure that one out, right? From a scientific point of view, you probably have a propensity in that area, but over years, you rewired your own brain with higher efficiency, faster conduction, literally can swell and enlarge in that area as opposed to someone else's, right? So if we kind of look at that muscle fatigue, unknown to you, starts to cause swing alterations. It's unconscious. Your own brain is saying, this muscle is tired. I need to give it some help. And all this is happening on an unconscious level, right? Well, that recruitment of help and some other things start to cause the initial fatigue to then start resulting in what's called micro traumas. So they're not clinical significantly traumas. They're not, it's not this huge swelling of a muscle because it tore or anything like that, but it's a slight swelling because small amounts of little micro amounts of fibers have torn. And so it's a small swelling that you can't even notice. In a pro, you don't register it. It's not pain. It's not debilitating. You go right back out the next day and play again.
Yeah.
No rest.
No.
More micro trauma occurs. These then start to accumulate, and you end up actually having either a chronic condition, which is kind of in my opinion, a worst outcome.
Yeah.
Or you have a more severe acute injury. Rest is important.
Yeah, definitely.
If you already feel you have to rest, I tell people, think of it like hydration. If you're thirsty, it's too late. You have to address it before you get thirsty. Same with microtrauma. You have to rest it and give it proper recovery before you have your symptoms, and then you'll have perfect recovery. Otherwise, you won't. There's something called muscle injury continuum, and that's where all of this is kind of coming from, right? It's a theory of injuries are a continuum from the really severe acute to the micro traumas, and we can move upon that continuum for that muscle group, even spinal group, at some point. And so that's how all of that kind of comes into play, right? So there's our kind of how. There's a how, right? Or the next will be the what. Right? So we talked about the lower back, we talked about the wrist, we talked about the elbow and the wrist, and then you have the shoulder. Right? So one of the kind of top three, we'll start with the shoulder, even though we're going to kind of, for lack of a better word, we're going to kind of go bottom up. We're going to talk with the least of the or the four majors, and then go to the most. Right? I want you to remember the most if I can. The shoulders, you have what's called subacromial impingement. So the subacromial area is you have your shoulder blades. We always called in med school, I was thinking it was wings. You literally look like you have little wings on your back, right? Mm-hmm. And they kind of come over here, and there's a little disc type thing that then the humerus clicks into, and then that's your skeletal muscle joint, right? Mm-hmm. That's, of course, you have your clavicle that then comes over, have the little disc, and the clavicle kind of comes and attaches like that. Okay, mm-hmm. So the subacromial is this is kind of the acromial area, is that connection there. Mm-hmm. So right underneath that you have groups of nerves, easily can be impinged with either muscles that have become inflamed, even sometimes bone structures and other things. Right, so that's kind of number one. How do I know if I have that? Right, so normally it's going to be a front top type of pain. It's going to be, people often describe it as achy. Right, so one of the things, if it helps, when I did a lot of the pain clinics, it was, if you feel an ache, 9 times out of 10, it could be, I'm talking musculoskeletal type of things, right? I have a tummy ache. That's a little different, right? If you feel kind of a muscle skeletal ache, we need to check nerves. If you feel a sharp pain, we need to check, did a muscle tear, did a bone break? Nerves tend to be more achy, right? So this is an impingement of a nerve. So it's going to be kind of top, front, and it's going to be achy to the point where it oftentimes will keep people from sleeping at night or sleeping as well. It's just really achy. People describe, I hear a click, click, click.
A clicky.
Yeah, it's kind of clicking.
Yeah.
As opposed to what's called a crepitus, which is like a grinding. That's going to be more of a joint arthritis. And so if you hear kind of a clippy, you're having problems sleep. It doesn't matter whether you're sleeping lying on it, and that's key, right? So for example, if you have a rotator cuff tear, the pain gets a lot worse when you lay on it. Like, so when you turn over, you're like, oh,
right.
But you go to the other side, and it's like, oh, rotator cuff is where we start to think. This is not 100% all, but that's where we're going to start, right? Also, rotator cuff, you're going to have weakness in trying to lift, and you're going to have more of a deep pain as opposed to kind of like a subacromial impingement. Be a little more surface, but if it'll be a deep pain. Worse when you're lying down on it. You'll have weakness in lifting, you won't have the range of motion you have. So subacromial, you can still have motion. It's fine, there's no motion. And then you'll have what I call the crepitus or crackling. So you'll move it and it'll almost feel like it's crackling. Okay. Those are rotator cuffs, right? So AC joint itself, arthritis, it's arthritis. You'll know it. It's deep. It's both achy and severe. And when you move your arm, it'll sound like basically bone rubbing on bone, because that's what it is, right? Those are shoulders. Elbows are very simple. They're much more common, particularly like you say in the winter. Either have a lateral epicondylitis or you're going to have a medial epicondylitis. How do I know which? Well, the first obvious one is it on the inside of your arm or the outside of your arm? But lateral is going to occur most often with a lead hand. Hitting those mats. Right. Hit the mat, my lead, it jars this, right? Medial is going to most likely occur on my trail hand because I'm more active here than I am here. right?
Mm.
So those are going to be kind of your elbows, your wrist. There are so many tendons here that can give you tendinopathy. I'm not going to go through them all. This is not an anatomy class. But the big thing that I would tell people, so you have something called a hamate, right? It's a bone in your hand, right?
Mm-hmm.
It's got a little hook on it, a little bony hook that then a tendon attaches and kind of runs through, right? If you're going to fracture your hand, that's one of the most common places of a fracture. So if you're having that kind of pain, you need to go get an x-ray done. It's a fairly common injury. And it can even happen because, for example, when you're coming down, you hit the turf wrong or you hit something wrong, the tendon itself can actually rip the hook off.
Mm.
Fortunately, that oftentimes will require surgery, but it's not required always. But it's definitely something we get looked at. There's plenty of nerves that run through your hand. They can be entrapped and impinged just like they can in your shoulder. The last one is the lower back, and we talked about this, right? So because I know you have a kind of a personal story with this one as well that's kind of dealing with this, and I know we talked about it quite a bit. Happened, but let's start with the physics because it's always a great place to start for me. If you are a 90-kilogram person, right? So 90 kilograms is roughly 200 pounds, roughly. Okay. So whichever one kind of floats your boat, your metric or other, shout out to Canada. Whichever one you kind of were, just think of it at 90 kilograms, roughly 200 pounds. Okay. You will generate a compression force on your lower spine of approximately 882 newtons. Okay, and that's just a measurement of force, but that can get up to 7,000 newtons in a golf swing. Okay, that's 8 times your own body weight.
Wow.
So if you think about that for a second, particularly on a kind of a back and downswing, okay, you can literally take the normal. We'll just make it easy, and we'll just say 1,000 Newton force, compressing your spine with your kind of normal weight of muscle mass and turning and that type of thing. When you activate or actively engage in a golf swing, you can multiply that by 7. That's like picking up 7 other people of your weight and putting them on your shoulders. That's significant.
Yeah,
right?
it is.
Now, one of the things that led me to medicine is I am fascinated by the fact that the human body can take that and does regularly.
Right.
I mean, people don't swing a golf club once and then like they're injured for life, right? Normally. What we do know is because you have these kind of compression forces, again, particularly on the downswing, that then leads to a number of other issues, right? So spondylolysis, where the bone itself is starting to be eroded, right? Disc generation, nerve impingement again, right? So people don't realize it, but your spine has joints, just like every other place in your body. Those joints can start to get worn out, and there's a cascade of problems that comes with that. Right? Just understanding, and none of this is intended for people to suddenly become terrified of their golf swing. That's not the point, right?
Yeah.
This is not an alarmist type of
Right.
call for everyone to stop.
Right.
No, it's be aware your body can handle this. But if it starts to go out of balance a little bit, the sooner, to echo kind of what you said earlier, the sooner you go either seek medical attention, rest, or do something and give your body the chance and what it needs to recover, the more likely you are to have a very successful recovery. And when we were kind of discussing this initially off camera, because it's kind of like most of our episodes, this comes out of just the discussion and debate that you and I kind of engage in off camera. I haven't completely covered all the physics or the physical problems yet. And I have yet to actually mention the mental, psychological ramifications
This
of
is
any of
just
this,
the physical.
which is why that's episode 2. This is just the physical. If anyone ever tells you there's not a psychological, mental, or emotional component of injury, you need to walk away from that person as fast as you can, because they're only interested in getting you hurt
Yeah.
and possibly injured for life. Because that's just simply the evidence tells you very clearly that is simply not true. And that is a very, very falsely held belief. Getting into that a little bit, one of the things I was telling you that as a physician particularly, there's some myths that I would come across a lot, and still do, that seem to get perpetuated, and I want to point them out because they do more harm than good, right? There's one I know that you particularly, we talked about, that you went, oh my gosh, I didn't know that. I'm actually, again, I'm going to save the best for last. The first one is, well, when I'm injured, apply heat. No. Do not apply heat. Heat can very much exacerbate swelling. It can very much exacerbate inflammation. It can very much exacerbate all those things that actually cause the problem, right? So oftentimes people don't know, but or realize this if you're not in medicine, but oftentimes the injury itself isn't what either causes you the most pain or ends up causing you the most problem. It's the inflammation and swelling that occurs after. And so we want to limit that as much as we possibly can, right? And heat will exacerbate it for an acute injury. Right? Now, if it's a chronic problem, right, which means damage is already done, it's healed, but you have these aches in this area, whatever, heat can absolutely be applied there. If in doubt, go with ice, go with cold in any way. And if it's any acute injury, cold, 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 cold. Right. So
it's the whole rice thing, right?
It is rice, which and I'll correct you on that one here in a minute. Yes and no. My daughter, both of my daughters, one dances and one plays golf, and both of them always get so frustrated with me because any injury they have, my rule is 20/20. So, and if your eyes are awake and you've got an injury, you're going to put ice on it set a timer for 20 minutes. You're going to take it off for 20 minutes. And you're going to put it back on for 20 minutes. And so I really don't care where you are or what you're doing. This is what's going to happen. They both have very, very expedient recoveries because of that. I learned that from an orthopedic surgeon years ago when I was doing kind of residency training stuff. And he's like, just 20/20. Just go with 20/20 and you can never go wrong. Because even if you're not injured, that's great. Right. You're not doing tissue damage. You're taking the ice off quick enough. And you're giving it time to seep in and work. And then you're allowing it to come right on top and get more to kind of begin to seep in. And he's like, so it's perfect. So for me, it's a 20/20 rule. The other thing is, and this is one that, on more than one occasion, I've had to stop a very well-meaning individual. And I'll be honest with you, coaches, don't call any one single type of sport, but your team sports, it seems to be very prominent and prevalent in, is, well, if you can move it, it ain't broken. That's not how that works. You can have a hairline fracture and have complete movement range of motion, right? And a worst case scenario, and you do actually see this at times, is because of that rule, someone thinks, oh, well, it's fine. And for example, they'll have a hairline fracture on their leg, right? Well, they continue to play, and that hairline fracture splinters, and the bone comes out the skin, right? When they never should have been having activity after that injury to begin with.
Yeah.
Right. And if you can move it, that doesn't mean it's not broken. Right. Now, like everything, take things with a little common sense. Right. That didn't break my finger. A large purple finger, even though I can still move or bend it, doesn't mean my finger's not broken. I need to get it x-rayed, and the x-ray will tell me very clearly whether it's broken or not. So, again, it goes back to the very beginning of professional advice. Right?
Yeah.
Not the final one, but one of the other ones is, rest alone is not recovery. It is not. That will play into the very last thing that, I tease you about with the rice. Thing is and some of my colleagues out there, particularly the surgeons, are going to get really upset when I say this, but to cut isn't always to heal, right? There are certain conditions surgery is the absolute answer for, and we should not be wasting our time with anything else. Just get them in the surgical room, get the surgery done, and let's heal this patient, right?
Mm-hmm.
So if you have tendon ruptures and tears, if you have unstable fractures, I mentioned the one where it's literally poking out, those are unstable, right? Surgery.
Mm-hmm.
You don't need PT, you don't need chiropractic, you don't need any of that crap. You need to go into surgery because that's the only thing the evidence says gives you the best chance of healing. Full stop.
Mm-hmm.
Full stop.
Yep.
Right? No argument on that one. Some people will want to argue with it, but no argument. On the other side of that, there is quite a bit of evidence and research out there that also shows that there's a number of other conditions that we call non-refractory, right? So an unstable fracture would be refractory to any other treatment. It's not going to change,
Mm-hmm.
right? It's until you get them into surgery, the problem persists, period, right? A non-refractory, if does actually respond well to what's called multidisciplinary and more conservative treatment, right? So, which then leads into the very last one, which you kind of I tease you about, is ask you the question. I remember at one time saying, you sprain your ankle going out to your car in the parking lot. It's a really bad sprain. What do you do? And you said, well, I go home and rice. I rest, ice
Yep.
it, compress it, and elevate it.
As long as I can,
As,
right?
as long as I can. And that was the part that I went, oh, as long as I can, right? And that is still a common belief. And what I will say to that is there's qualifications to everything. If medicine was so simple that you didn't need 12 years of training or an AI could do it, which they can't,
Mm-hmm.
we wouldn't require 12 years of training, 12 plus years of training, right? There are nuances to it, but for the very acute first, you sprain it in the parking lot, you get home, rice it. That's fine, right?
Mm-hmm.
But we actually have found out through research there's a new term that we call police it, right?
Mm-hmm.
Which is you protect it, then you have what's called optimal loading on it. And you ice it, compress it, elevate it, right? So it's police. What that means is what we found is people who just do rice for as long as they possibly can and just rest it have a significantly poorer recovery and longer recovery time than people that police it. So by graduating activity with it, and we're protecting it, but we're still putting some load, a little bit of a load on a muscle injury, for example, we are triggering and forcing the body to get into the recovery mode, as opposed to just resting it, icing it, compressing it, blah, blah, blah. We're actually causing it to get stiff,
Yeah.
which can either cause long-term disability, unfortunately, or
Mm-hmm.
long-term dysfunction and delays healing longer than it should be.
Mm.
So nowadays, it's the reason why I tell people that the clearest, easiest example would be, it used to be you'd go in, and I know this isn't an injury per se, but it's the same concept. You get appendicitis. You go in, years ago, they cut you open, take your appendix out, and you're laying in the hospital bed for a week, right? Now they go in, they scope you, take it out, and you're up walking the floor within 2 or 3 hours after surgery. They literally expect you to walk around the hospital.
Mm-hmm.
That's optimal load bearing. where it's like, no, 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 you can't sit there and just lie in bed.
Right.
You have
No.
to stand up. You have to cause that core muscle group to begin. Yes, it's angry because we cut it, but we're going to force it to start healing. Right? And so those are some of the common myths, and we want to kind of dispel those a little bit. If in doubt, go seek medical help. But rest isn't always the answer, and rest does not equal recovery. Rice is not a bad thing at the very, very beginning. Just don't do it. Like, either go to the doctor the next day or you need to start policing it. You know,
I love that. I
yeah.
like that term.
Isn't that great? I was like, I thought it was
Yeah.
a great way to remember it. I thought that was a great kind of acronym. I agree. I think that's a great acronym too. Don't put heat on an acute injury. Please, just you're hurting yourself and you don't realize it. And just because you can move it doesn't mean it's not broken. Those are, and I will ultimately lead any decision for surgery up to my colleagues that specialize in that. There is quite a bit of evidence, and my surgical colleagues are aware of this. They know this. I'm not saying anything they don't know too. But there are a lot of injuries that don't require surgery. So you don't need to immediately go in and, oh, I got an injury. You need to cut me open. Listen to them if they tell you, no, I don't. It can be very hard with the lower back injuries, but there are some good studies that show even people that have herniations in disc, not always. I will echo my neurosurgical colleagues that I typically work the most with, in that it really comes down to what the initial presentation is. So, for example, if you're having paralyzation issues, we don't wait for surgery. Conservative treatment will never ever help that.
Right.
It will never fix that, and quite frankly, it ends up causing long-term disability in someone that could have been prevented. That is a little bit of a problem we're facing today. Is a lot of insurance companies and things like that are wanting to delay. Well, we'll send them to PT first. We'll send them to this. Well, if they can't use their limb, that's very different than I'm having pain. They don't seem to differentiate that for some reason, and it's caused a lot of permanent disability that never should have happened. I shout out to my neurosurgicals. I know that is a constant frustration for them. But on the same side, there's people that come in, they'll have a herniated disc or something like that. Research has shown that given the proper adjunctive treatments to it, PT, policing, things like that, then in 3 to 6 months, that herniation can actually heal itself sometimes. Now, if it doesn't, then we need to look at surgical options if it's a horribly debilitating type of situation. As hard as it can be to have those lower back problems, and they can be significantly painful. Sometimes we just got to find a way to manage the pain through neuromodulation or something else, give that a chance to heal. And conservative treatments can actually help there, as opposed to just go straight into cut.
Yeah.
I went over a lot, and we were.
This is just the
physical. I have not mentioned psychological, emotional components yet.
So this is just part
which is
1.
why we have part 2.
Exactly.
Because unless you want to sit through like a 2-hour type of thing, I don't think we can do that.
Right.
A little bit of a sneak peek, no spoiler alerts, but sneak peek, that the cognitive, emotional, psychological impact of injuries can actually be as great or even greater than some of the physical components.
Yeah,
and
for sure.
And so that is something, it's a little more recognized in certain sports, but in a lot of sports and professional levels, I can't quite figure out why it's not, but it's something that should absolutely be a component of any care and recovery.
For sure.
If you want to optimize a professional performance.
Yeah, definitely.
And
that's something overlooked.
Very much. So it's one of the reasons why I ended up kind of moving away from my former job, because I saw that. Why I kind of do what I do now is how do I help either educate or even help these professionals, because they're not getting this type of component of recovery. They're only focused on the physical. they don't really even see how their physical recovery is severely kind of, there's a time retardation type of there where it's causing a prolonged recovery period that could have been shortened just by addressing the psychological, mental, emotional components during the injury recovery. I mean, you can cut the time almost in half at times.
Yeah.
There's a few cases that I've come across both in my clinical career and now where someone that literally ends up leaving their profession, professional sports specifically, because of an injury that they could have continued. In terms of the physical limitation, it wasn't there. It ended up being just simply a mental emotional. I agree, it's something that's overlooked quite a bit. We'll even talk about that because golf itself at a professional level, and this even can, you know, again, I'm not trying to purposely separate genders, I'm just making objective observation. Seems to be of higher prevalence and incidence in female golfers than males. There's an even isolationist component that can cause significant problems at times. Yeah.
Definitely.
Yeah.
So this is the impact of injuries physically. Make sure to tune in to our next one, which will be the mental and psychological effects of these injuries. So please like and subscribe to our channel to hear more.